Hi, my name is Rochelle Oliver Small, and this is for NU 675 for week 10 on crisis management. Today we will talk about two patients. Our first patient, a 45-year-old male who has been married for 15 years with two children. He has a history of major depression disorder and pornography addiction, which has been dealt with through therapy. The addiction has caused some trouble in the marriage, but for the past 5 years, things have been going well in the marriage, and the patient denied looking at porn. MDD symptoms started in his 20s and have been well managed with Celexa 20 milligrams. He comes in today visibly upset. He reports his wife has been cheating on him for 2 years, and he found out when she came home from work to find his wife and kids gone. A note that detailed their infidelity, and she took the children to live with the man that she has been cheating with. Divorce proceedings are in effect. He states, I have no idea. I know I had my own problems, but 2 years, I feel so stupid. I don't know why I bother improving myself. I don't know how I can even go on. My work made me take some time off, but I have continued to call in. I'm at risk of losing my job, but I can't bring myself to go. The kids are my world, and I haven't even talked to them for a month. You question him about suicide and homicide ideations, and he replies that he has been suicidal since she left and has been drinking at least a six-pack at night. He has had plans to shoot himself. When asked what is keeping him from acting on his plans, my kids, but I lose hope I'll ever see them again. What are your next steps? As for me with this patient, in this case as a psychiatric nurse practitioner, I must ensure that this patient is his safety first. His language showed active suicide thoughts, wishes to shoot himself, and increased alcohol intake. I would then use the risk factor identification in accordance with the suicide assessment 5-step evaluation and triage, also known as the SAFE T model, which covers his previous major depression disorder, his MDD. The presence of psychological stresses in his life, drug use, and access to guns. These elements feature a great danger of him committing suicide, and this might demand emergency treatment. Immediate safety and stabilization. The patient also stated that he has a plan and he wants to kill himself. This is why I would have a full suicide assessment and activate emergency safety measures. I would establish an objective to estimate a therapeutic relationship that would lead to trust and openness by using an interpersonal therapy. I would also ask whether he has access to the guns at this moment and coordinate with the family or with him and the family to get it out. Because his risk is acute, he would require hospitalization, which is voluntary to stabilize and be safe. In case B declined, I would pursue that state procedure for involuntary examination. During this process, both empathy and calm communication will be required to minimize the anxiety and facilitate cooperation. Therapeutic communication and emotional support. My interaction with the patient was centered on acknowledging his pain and showing empathy. I would say words like, it seems that you are utterly devastated at the moment, to show empathy, but at the same time be professional. I would not downplay or provide a short term solution. In crisis work, the idea is to assist patients to regain control and feel supported instead of solving all issues simultaneously. I would stress the idea that this is a way out and that his present state of despair can be treated. Involving him in the following steps will support autonomy and optimism. Intervention planning and collaboration. The second step would involve reevaluation of his medication and involvement of the multidisciplinary team once he is stable. His citalopram treatment has been responding well in the past, but due to the advancing depression, a dosage review or addition of therapy might be required. I would involve psychiatric and take into consideration short-term medication to deal with agitation or sleeplessness. Because alcohol consumption exhibits symptoms of depression and impulsive, I would discuss the possibilities of the treatment of substance misuse and refer to a dual diagnosis program. Engaging a social worker will also assist in dealing with stressors related to divorce and linking him to legal or community support. Family and social support. Through his relationship with his wife, though his relationship with his wife has ended, I would seek alternative means of emotional needs, including family or extended family. After discharge, supportive people would assist in monitoring and decreasing isolation. In the event he agrees, I will promote family participation in enhancing compliance and safety. I would also give psychoeducation on how alcoholism and sleep deprivation increases mood swings and suicide ideation. It might be beneficial to him, linked to the loss or divorce therapy group, to help him through his divorce journey. Follow up and long term management. I will schedule close follow up visits to assess his mood, sleep, and safety after the crisis. An adequate way of empowering him is to respond to distress in the future would be develop a written safety plan, which entitles warning signs, effective coping skills, and emergency contacts. The cognitive behavior therapy, CBT, would assist him in eliminating distorted thinking as well as restoring self-esteem. The process of recovery would be a gradual process, and any aid with the daily routine would be useful. I would also focus on empathy, hope, and restoring meaningful relationships, and in particular relationships with his children as soon as possible. In conclusion, safety and collaboration are involved in the crisis management for such a patient. The evidence-based suicide prevention, therapeutic communication, and multidisciplinary coordination and integration will help me to stabilize him in the case of acute distress and help him in long-term recovery. The case supports the significance of quick evaluation, collaboration, and relationship with the patient when dealing with psychiatric crisis.